Well, good morning, everyone, and welcome to the 2024 or 2024-25 academic year, beginning our grand rounds. Our internal medicine grand rounds usually starts with the chair giving a state of the department and talking about some academic subject, and I've had the pleasure of doing that a couple times, but this time the beginning of our grand rounds actually happens to be during the start of the American Society of Nuclear Cardiology meeting. So I'm here in Austin, Texas, hoping to find out a whole lot about the newest and latest nuclear equipment so that we can actually put new stuff both at the University Hospital and at Jewish Hospital. But that the other thing that's going on is that my grand rounds had to be delayed because it actually was talking about something very new. And I'll introduce it just by saying that there are going to be new perioperative management guidelines, and I hope you all will attend my grand rounds. But it's still embargoed by the American Heart Association until September 30th. So Dr. Bhatnagar has stepped up to the plate. What a wonderful designated hitter to have. And he will take my grand rounds and I will take his, and that way I won't break that embargo. So, but I really want you to invite everyone to talk a bit about how their department is doing and a lot about the perioperative management guidelines that are coming out later in this month. And that'll be my grand rounds on October 3rd. But this morning, it's very much my pleasure to introduce to you Dr. Jennifer Cook, who is our Vice Chair for Academic Affairs and Faculty, and she will do a proper introduction for Dr. Bhatnagar. But before he does, I want to remind everyone about our grand rounds that we have at noon. That is our research grand rounds. It's going very well, but I heard through the grapevine that there are people who didn't know that it was going on, and that there was a wonderful plant-based lunch that happens every Thursday. And so I'm inviting you at noon to hear wonderful talks. We have had a fantastic series so far of research-focused grand rounds, and this is an open invite for anyone who's doing clinical or basic research in the department or even out of the department to give us a call, and we can try to get you all set up and onto the schedule for that. With no further ado, Dr. Cook.
Okay, thank you, Dr. Williams. Welcome, everyone, to the first grand rounds of the school year, as I like to call it. Today, I have the pleasure of introducing my colleague, Dr. Aruni Bhatnagar. Dr. Bhatnagar has been with the University of Louisville since 1998. And though his Ph.D. is in chemistry, his career embodies the true meaning of a multidisciplinary approach to the health sciences. He's held faculty appointments not only in the Department of Medicine, but also in the departments of pharmacology and toxicology, physiology and biophysics, and biochemistry and molecular biology. And that's quite a collection of departments you have there. Dr. Bhatnagar is the founding chief for a very unique division of our department, the Division of Environmental Medicine. And he also serves as the director of the Christina Lee Brown Envirome Institute. His CV includes well over 400 peer-reviewed publications and over 130 invited speakerships nationally and internationally. And today he'll speak on testing the clinical efficacy of Carnosine against cardiovascular disease risk and peripheral artery disease. Thank you, and please join me in welcoming Dr. Bhatnagar.
Thank you, Dr. Cook, and thank you, Dr. Williams, for this opportunity. It was good fortune that you were not here, so I could talk about some of the stuff that I've been really interested in lately. I'm sure you've heard me speak about a lot of things, but this is a sort of another facet of our work, which has to do with some of the clinical studies that we're almost about to undertake. So what I would do is to present to you a background of why we are doing this work, what is the preclinical data supporting this work, and the conceptual scientific premise for looking into it. So I would begin with sort of submitting to the idea that a cardiovascular system is complex and is very essential for generally all systemic health because it applies to all peripheral organs, and it's critical in maintaining the flow of nutrients and removing waste. And given this central importance, it is no surprise that it is anything that goes wrong in the circulatory system has profound consequences. And here you can see that the leading causes of death, and 3 of the top 5 have to do with something wrong with circulation of the heart. And so this sort of underscores the importance of the circulatory system, both as a sort of a manifestation of the overall health of an individual, but also as a critical system that contributes to more than half of mortality and morbidity, not only in the United States, but in the entire world. There used to be times to think cardiovascular disease was just in developed countries and advanced countries, but now it is also in middle-income countries and sometimes in low-income countries. So regardless of the amount of treatment that we have for this, the incidence of the disease keeps growing. So we need to understand its basic physiology and mechanisms. And not only that, it is the rates are high, but the American Heart Association estimates that the rates are going to increase in the near future. And by 2030, about 40% of US adult population will be living with some form of heart disease. So this is really startling because given the advancements in medical therapeutics, interventions and treatment and management, we don't seem to understand the basic nature of the disease and why we have this rising incidence of the disease despite such good control. So we know that the disease progresses through many stages, and these stages could start with a fatty streak, which is an accumulation of what we call foam cells in the subendothelial layer of the vessel, and then progressively grows from an atheroma to a fibrous plaque, and eventually it leads to plaque rupture, which is sort of responsible for cardiovascular events. The underlying mechanism relates to the actually ingress of the LDL particle in the subintimal space of the vessel, where it attracts a range of inflammatory cells, and these cells accumulate to form the atheroma and actually later on the plaque. So we need to understand what the underlying mechanism is and where they could be intercepted. And once you have an advanced disease, you can have a range of changes in the vessel wall, which leads to the formation of a fibrin thrombus. Sometimes when there is actual leakage, there is calcification, there's accumulation of lipid. And sometimes the arteries harden to the extent that it becomes difficult for them to be compliant. There's actually an old story about this physician in the medieval ages. He was dissecting a human cadaver, and he found the artery was so hard that he thought somehow the plaster from the ceiling has fallen into the cadaver, because they were just like they were calcified to the extent that they seemed like to be made of plaster. So this poses a real challenge to understand such a complex and multifactorial upper disease progression. But whenever all the clinical events are related to the development of atherosclerosis, atherosclerosis is the underlying cause of coronary heart disease. It is also responsible for stroke, because it also is a blood clot that blocks the artery because of the buildup of cholesterol plaques in the brain. And it is also responsible for peripheral artery disease, which contributes to major morbidity and mortality. This is a very critical disease. It affects about 8.5 million people in the United States and over 250 people worldwide. And it is, I would think, somewhat understudied for its own sake. The treatments are not entirely as effective as we would like them to be. And there is a great unmet need in trying to understand PAD and manage its consequences. This sort of disease starts with narrowing of the artery. And so this narrowing can lead to blockage of the artery, which could interfere with blood flow. And you can see that here much more clearly. You can see that there are gaps in flowing of blood, and that leads to underperfusion of peripheral limbs, which are then cause a variety of different symptoms. And these could be sort of a pale bluish color in the skin, weak or absent pulses in the legs and feet. There's a loss of hair on the legs, so you can see that the legs are not well perfused. And there are sores and wounds in the toes and feet, and that wouldn't heal. In fact, it is a very common, frequent cause of limb amputation. So it is a very serious, problematic disease, and unfortunately, it's quite prevalent. It is distributed there are more women and persons of color who are at higher risk for this disease. It is very often underdiagnosed or undiagnosed. And several risk factors contribute to disease, such as smoking. Smoking is actually very, very high sort of risk factor for this disease. There's diabetes, age, hypertension, of course, dyslipidemia and endothelial dysfunction, all of which can contribute to the pathophysiology of the disease. And it presents as sort of sometimes as atypical symptoms and sometimes as in a late presentation where there's also very advanced blockage of these peripheral arteries. And there's intermittent claudication, that is pain that accompanies just by walking, and some of these people cannot even walk straight for 6 minutes. So it is a major serious sort of morbidity associated with the disease. And like I said, it's sort of associated with rates of amputation. And we have a lot of disparities in managing disease. We have, especially in people who are most at risk, we have low rates of screening, we have poor interventions and higher rates of amputation, and we don't have sufficient clinical data to be able to understand how to monitor and sort of reverse or mitigate the symptoms of the disease. The disease actually progresses with age, and as you can see, it sort of varies with ethnicity. So those who are Black individuals are much more at risk, as you can see, followed by Caucasians. So it is really startling that in late age, over 80, about 25 to 30% people actually have the disease, which is startling. And so it needs sort of a different management. What we do right now is to be able to somehow increase flow to the limbs. But when you don't have enough perfusion, you act because of sort of accompanying inflammation and oxidative stress and loss of cells through apoptosis. You get imbalance in the muscle structure, and you get loss of neurons, you get microvascular changes and general muscle sarcopenia, so that there is limited mobility and limited perfusion to the limb. As you can see here, that with sarcopenia, there's extensive loss of muscle function, and that could be in some cases this is reversible, but in most cases it's not, because some muscle usually upon exercise can develop and grow, and muscle cells they have satellite cells that can fill in, but this sort of proliferative response is prevented. Currently, we treat the disease with some antiplatelet pharmacotherapies for claudication, so you prevent formation of clots. But it's unclear whether there is these things, any of the drugs used today are better than aspirin. There has not been a head-to-head sort of inferiority or superiority trials with any of the monotherapies. Sorry, and then there are concerns about the side effect. The most common therapy or intervention is to do stent, which is to reestablish the blood flow in the peripheral arteries. And you can see that sometimes this could be achieved with great success, that instead of the blocked artery could be cleared. But the procedure is sometimes not possible with the sort of anatomy of the lesion. And so it's very difficult to access the lesion. And so these patients are called the no-option patients. And then sometimes arterial grafts can fail. So if you do grafting, that could be problematic. So you cannot, in some cases, very difficult for this treatment. And sometimes even when you do you stent an artery, it reoccludes, and so there are all these problems associated. So there are still a lot of there is still a lot of need for alternate therapies. One of the therapies that's been tested is exercise training, and it's a very effective way to reduce limb morbidity in this disease. There's the results of a trial which is called the CLEVER trial, and what it compared was optical medical care and supervised exercise with each other. And this is the change in the walk time from baseline to 6 months in minutes. And you can see that with optimal medical care, it was 1.2 and 5.8 with supervised exercise. And the stent recovery was only 3.7. So you could see that exercise is even better than stenting. And it's very unfortunate that clinically we do not, in this place or any other place in town, you don't have supervised exercise training for PAD patients because we are so, I know, eager to do the stenting for that. We never really think that non-stenting, non-surgical procedures may be equally or more effective. And that has to do with payment structures and reimbursement and so on. But it's very unfortunate that a very good treatment is sort of ignored quite often. But we know that exercise is very beneficial. It can improve mobility, it increases the strength of the muscle and endurance, and it can cause the muscle to grow, which is called hypertrophy. And you know that if you go to the gym and you work out, you build muscle. So that's what the hypertrophic muscle is. It can also increase angiogenesis and formation of new capillaries and increase perfusion of peripheral organs. So therefore it has a multifactorial effects. So it needs to be considered. So what we did was to look at what happens with skeletal muscle during exercise. And this was one study with 20 individuals, and they went through this sort of HIIT training that is to do extensive exercise and for about 8 different sessions. And we took biopsies of the muscle before and after the training. And what we found was that there was a sort of a dipeptide which was increased. And then if you give them precursor dipeptide, we found that upon exercise, there was an even greater increase in this dipeptide. So what is this dipeptide? It's called carnosine, and it is a dipeptide that is composed of 2 amino acids, alanine and histidine. It is a family of peptides like carnosine, carnosine and carnicine, anserine and acetylcarnosine and homocarnosine. So all these different molecules, and they are present in very high levels in muscle. I'll show that in a minute. Some animals, for example, like whales, who spend a lot of time at low oxygen concentrations, have very, very high concentrations of peptide in their muscle, something like 100 millimolar or so. In humans, it is about 15 to 20 millimolar in the muscle. It is very high in olfactory bulbs, but also skeletal muscle and other organs as well. So this is a very high abundance peptide that is present throughout the animal kingdom and most skeletal muscles. And in fact, the muscle is a good source of this peptide. So if you eat meat or your turkey breast, chicken breast, one of the highest levels of carnosine that you can find in food. It is actually a very good buffer. It has a pKa with ionization potential at about 7.2, which is very close to the physiological pH. So it is a very good buffer. It's a mild buffer, but it is it is a high buffering capacity because it can go through different forms in terms of its protonation. It is used as a performance enhancing drug to be able to boost your exercise training and endurance. It is boosts endurance, and it delays muscle fatigue, improves athletic performance, and enhances recovery. So all of this, I think, is just, I would think it's advertisement. I'm not sure that much of this has very good scientific basis, but regardless, it is used very commonly by long-distance runners and cyclists. I've heard stories that when we had the UK Olympics, everybody in Britain was using carnosine, so they got all these medals, and the Chinese got into the act. So when they had the Beijing Olympic, then all the Chinese got all these medals, and this is all because of carnosine. The interesting part is because it's a natural food substituent, you can't detect it on any test because it's just normal. It's a normal body chemical and normal constituent of food. So in any case, the claim is that it works by buffering the pH in the leg. So when you exercise, you get lactate buildup and you have pH decreases. So if you have this buffer, you can buffer the pH so that you can have more glycolysis longer, so that you'll be able to exercise and work out more. But it can do other things. Carnosine can actually react with products of lipid peroxidation, and these lipids such as acrolein and 4-hydroxynonenal, it can sort of react with what we call the advanced glycosylation products or end products or AGEs. And so that may be another mechanism. It can also chelate metals, which can prevent oxidative stress. So we wanted to see if there was any evidence for this. And so we collected urine and then analyzed by mass spectrometry. And we found that this particular peptide forms conjugates with different products of lipid peroxidation. For example, here is propanol, there is H&E and so on. So this was an indication that this chemistry actually operates in human beings, and we can see that carnosine is reacting with toxic species and then removing it in the urine. Then we try to see whether this could be an indication of the state of which of a particular individual. And I apologize for this complicated slide, but you can see that there is a sort of here a greater excretion of carnosine conjugates in males than in females, in smokers than in non-smokers, and in older people than younger people, so that we could use the extent to which these particular metabolites are in the urine to assess cardiovascular risk. And this is shown here. You can see that people without diabetes have lower levels of this metabolite in the urine, people with diabetes have higher levels, and people with sort of lower normal HDL have low levels, but people with lower HDL have higher levels. So the levels at which these conjugates of carnosine are excreted could be a relative predictor of cardiovascular risk. But then we saw that we need to understand whether this is actually effective in preventing atherosclerosis. And so this is a mouse study. And what we did with this, the compound we give is called octanol carnosine. It goes through membranes easily, but it's just carnosine. So when we fed these mice carnosine, of course, the carnosine levels in the plasma, spleen, and the aorta went up. These are sort of aortic leaflets of the mouse, and the red stain here are the lipid deposits, and you can see when you feed the mouse carnosine, the lipid deposits are decreased. And this is staining for macrophages, which I was showing that how macrophages go into subendothelial space. So we can measure these macrophages. You can see that the levels of macrophages are decreased when the animal is fed carnosine, and the overall lesion formation is sort of attenuated. So it was seen that at least on surface, carnosine works by reducing oxidative stress, and that leads to a decrease in lesion formation and plaque formation. But the other thing we wanted was, because you were interested in peripheral artery disease, we thought, let's look at what happens with hind limb ischemia, and would this be effective? So this is again a mouse in which we tie up the artery here in the limb. And so you can see in comparison to this limb, which is all red, this is bluish, which means the blood flow here is prevented. And if you treat with carnosine, there's more blood flow in the limb than when it was not treated. And this is just shown here that treatment with carnosine leads to better recovery after hind limb ischemia. And this also shows that there may be much better preservation or growth of blood vessels when you treat with carnosine compared to when it was untreated. So not only could this prevent the atherosclerotic lesion formation, but may be able to promote recovery after hind limb ischemia. So it would be a good profile to test clinically. Then we wanted to see if it affects angiogenesis and muscle proliferation. And you can see that treatment with carnosine enhanced proliferating myocytes, as well as the capillary density in the skeletal muscle. So that was sort of encouraging and reassuring, but we wanted to see if there was any functional improvements, and this is just movement of the animal after the limb ischemia. And you could see that upon treatment with carnosine, that there were sort of improvements in most of the indices of movement. So not only were there structural and histological changes, but also functional changes. And this is showing again the blood flow levels, and upon treatment here, the blood flow in this limb is much greater than the other limb, and this is shown over here. So that sort of is what provided us the premise to be able to say, well, now we can actually use this clinically and be able to provide some preclinical data. Of course, the whole series of studies took us almost 10 years to complete before we can even dare to suggest that we can do a clinical trial, even though this is a very well-tolerated food supplement and used extensively to enhance performance. The other thing that we wanted to see was whether or not it will, when it does prevent this injury? How does it promote it? And so one of the things that is involved in repair of blood vessels are these cells called endothelial progenitor cells. And when you give these stem cells to an animal, you can see that there is increased growth of blood vessels, so they promote growth of blood vessels. So what we found that these cells were actually made dysfunctional by exposure to air pollution and other noxious chemicals, and then we want to test whether carnosine would actually prevent that. So that's shown here, that when you have these mice which are exposed to air, they're just breathing air, or concentrated air particles. We have a facility here that actually concentrates air particles from downtown Louisville and then pumps it out to mice. And so we can compare the mice exposed to filter air and to polluted air and see what the difference is. So when we expose mice to polluted air, the doubling time increases, so the cells have difficulty growing. But when we put carnosine, then this growth is restored. The same thing we see as capillary formation, that there is when you're exposed to these concentrated air particles, your tube formation goes down. But when we treat with carnosine, this effect is prevented. This is all complicated series of experiments, but I just want to point out one thing, that when you take a mouse and expose it to this air pollution, and then you take out the EPC and then try to put in the other mouse to see if that will promote the growth of blood vessels, it works. But when you have the mice exposed to air pollution, then that's prevented. So then we can see here that although this normal mouse EPCs can promote limb recovery, the ones exposed to air pollution do not. And then when you treat with carnosine, you can see that it's much better than that. So it is just that carnosine can actually prevent these toxic effects of the environment and restore the functional capacity of stem cells to be able to stimulate or catalyze the growth of new blood vessels. So then we said, okay, now that we have all this data and that we can at least have some level of confidence that this particular neutral supplement can promote vessel growth, can promote recovery from hind limb ischemia, and can prevent the effects of air pollution and actually cause muscle growth. We thought we could test it in humans and do a clinical trial. So this was one trial in which we did a double-blind placebo-controlled trial to test the efficacy of carnosine. And it was randomized, and we enrolled over 240 participants over a year. It was a single center trial, and we treated them with 12 weeks of carnosine. The hypothesis was that when you expose to air pollution, you generate all of these noxious chemicals, and carnosine will be able to prevent it. Of course, we have not yet sort of fully analyzed the data, and we don't even know whether the primary endpoint is that, but we got some sidetracked, and I'll show you some interesting data according to that. So this was just our sort of timeline of how we did the trial. It was an extensive undertaking, and then we were able to enroll our target number of patients or participants. First of all, we wanted to measure levels of carnosine in people. And it's very difficult to measure. In the skeletal muscle, people are not very happy with muscle biopsies. And so you can't get 240 people to come in and say, I want like chunks of your muscle. So no, athletes do that. I mean, we've done the studies somehow in the United States, people are more queasy. And all the studies we either did in Belgium or Australia. And so all the athletes there say, oh, we want to take some beta muscle. And they're like, okay, fine. And then after exercising, we got it again. And so they're fine with that. But here, people are very, very particular. So regardless, so we have to find a way of how to measure in vivo levels of carnosine. So we looked at the red blood cells, and we said maybe the measurements of carnosine, the red blood cells, could be an indication of the in vivo levels of carnosine. So we measured in males and females and people of different ages, and we found in general that males have more carnosine than females. It can be whether because male muscles are bigger, or maybe because there's different chemistry, more endurance, whatever the reason may be. But there definitely much higher levels of carnosine in males, and then it's sort of older people seem to have slightly higher levels of carnosine, both males or females. I think the BMI didn't make any difference, so we could at least get some idea of what the basal levels are. We then looked at carnosine levels in the red cell and then tried to see if it's associated with the levels of carnosine in the urine. So we saw there was relationships, so maybe there's a relationship with how much carnosine you have in your body and how much you excrete. Then we fed them carnosine. And this was for 12 weeks, and we wanted to look at whether that led to an increase in carnosine, whether everybody would see an increase, or some people see an increase, some people don't see an increase. So we actually analyzed the data in different categories, found that everybody saw an increase in carnosine levels, everybody saw increased carnosine excretion, and increased clearance of these conjugates. So that means that the more carnosine you eat, the more it binds to your oxidized chemicals and removes them. So that we saw that there was no change in age or sex or how long the treatment was. 6 weeks seemed to be enough. So it sort of reassured us that our treatment was working and what we're supposed to do, what we're supposed to be doing. So this was the digression. So if you remember the many slides ago, I was showing that carnosine is present in many tissues. It's also present in the brain. In fact, if you have a deficiency of enzyme called carnosine synthase in the blood, which breaks down carnosine in the food and helps absorb beta-alanine into your brain, then you develop some sort of neurological defects. It's called carnosinemia. And so the brain also functions on glycolysis, requires buffering, just like skeletal muscle does. And so what we thought that if you're feeding these people carnosine, we should test their cognitive function. In fact, there were stories or abstracts and papers published showing that if you give carnosine to combat soldiers, that their performance is increased. They'll be able to concentrate better, their target practice better, they can focus better. So it may have some cognitive effects. So we did a really extensive battery of cognitive evaluations that are showing all of this here. It sort of measures sort of risk of decision making, spatial orientation, working memory, abstraction, and then speed, sensory motor speed, and spatial memory and learning. This is just a flowchart showing how many people. There were about 299 people initially. We had to exclude some of them, and then finally we have a fair number of people, 230 people. So it's a moderately well-sized, well-powered study. So first of all, we looked at cognitive function with age, and what we found that sadly all the cognitive functions decrease with age, and therefore. Say a 51-year-old and a 35-year-old, there's a really remarkable difference in the speed as well as in accuracy and efficiency in completing cognitive tasks. It's a well-known effect, so there's nothing new here. But what we found was when we gave carnosine to people under 35 or to people over 36 and 50, that the speed was improved, efficiency was improved, accuracy did not change. But after 36, there was no effect whatsoever. So it only helped people who were younger. Maybe age was such a sort of overwhelming factor that it was difficult to make any changes or any improvements, so to speak. And this is the whole battery of tests that we did. You don't have to go into this, but it's all spatial learning, memory, recall, accuracy, speed. And when we look at people under 35, you see there are improvements in many of these. You can see so many stars. So there's improvement in many of these cognitive tests upon feeding carnosine. But as you look at older people, there is very little improvement. And after 51, there is no improvement. Actually, maybe a slight decrease here. So age is such an overwhelming factor that we couldn't sort of improve that by treatment. But for younger individuals, this is very effective. So we are sort of putting this together and trying to publish this. But it was interesting that it showed. We also sort of analyzed differences in cognitive function from individual demographics, and we're still trying to figure out what the effects of carnosine would be, how it selectively affects men versus women, and so on. There wasn't much of a difference, but the effects were very similar. So the idea then is that if you give carnosine, its efficacy is high, and then it sort of decreases over with age. And so the placebo remains mostly the same. So the effect disappears after some time. Anyway, going back to Ph.D., which was which was our main interest. You want to see whether it would have any effect on peripheral artery disease. So first of all, we wanted to see whether PAD would affect the excretion of carnosine. And so these are data from 204 normal participants and about 90 some PAD subjects. And we looked at the levels of carnosine in the urine in these individuals, and we found that there was a decreased levels of carnosine here. So that may be either a symptom of dysfunction of the muscle or just simply loss of muscle. So the less muscle you have, the less carnosine you will have. And so that's why that might be a decrease in carnosine levels. We looked at the levels of the expression of the enzyme, which is the carnosine synthase in the muscle. And this is, we saw compare normal and severe PAD patients. And we found that with PAD, there was a decrease in the levels of this enzyme. So not only do these individuals have low carnosine excretion, they also have low levels of carnosine synthesis. So then we enrolled people to look at their characteristics and effects. So this is just a demographic table in this population. They are being stratified or divided into different categories by this is the ankle brachial index, which is you measure blood pressure in the arm and in the leg, and then you see the difference. And so that's sort of the most frequent or common ways of diagnosing PAD. And so we have the PAD levels, which are the ABI levels, which were really very severe or moderate or mild, and we can then look at sort of different characteristics and then be able to see whether there'll be any changes upon treatment. This is just the effect of carnosine. So when we gave carnosine to people, we want to see if there were any systemic changes, that metabolic changes, lipid changes, changes in iron regulation or liver function and kidney function. So we didn't find much of a change in any of those things. So it is not like generally causing some systemic change. Maybe there are only some muscle specific changes. Then we looked at the 6-minute walk test, which is supposedly the gold standard for looking at functional changes with PAD. And this is a small group of patients because this is about a preliminary study that we're doing. We're still going to the clinical, the big trial later this year. And so we saw that after treatment, at least in a small select group for 12 weeks, the distance covered by the individuals in 6 minutes was improved in those who were treated with carnosine. And this was about 2 grams a day for 12 weeks, which is quite a lot. It's a long process and very difficult to maintain these people in the trial. And then they have to take these pills twice a day, and then the others have to take placebo. And so it's a relatively involved procedure. But the good news is that with the preliminary data, we went to the NIH and we convinced the reviewers that they would let us do the full trial. So we are now, we just got funded like last week, and so we're now to continue and do this in many more patients. But to do that, we want to look at what the changes would be and whether there is, what are the targets? How do we measure carnosine levels? And so this is sort of illustrative examples of how to conduct a circumspect clinical trial. So you not only have to have preclinical data to be able to strengthen your scientific premise, but you also need to have ways of measuring the intervention, the efficacy of the intervention, the primary outcome, and then the study should be adequately powered. And then you need to understand what the underlying mechanisms are. The NIH was a little bit uncomfortable with us doing the clinical work and the mechanistic work in the same project, where we convinced them that no, I think understanding the mechanism was critical to understanding the efficacy and outcome. Okay. So what we did was to look at what the targets could be. So we looked at VEGF, or vascular endothelial growth factor, which is a key molecule that causes that improves angiogenesis. And so we wanted to understand whether or not this would be effective. We indirect measure of angiogenesis. And so again, we did normal and severe PAD patients, and we can see that there was a decrease in the levels of VEGF in their muscles. And so that would say that there is sort of lower levels of angiogenesis in these individuals, and that could be sort of studied with carnosine. Then we want to say, if you give carnosine, can we measure it in terms of its intervention? Did it improve the levels of carnosine in individuals? And again, we need to measure carnosine levels in vivo. It is difficult to get skeletal biopsies, so we looked at red blood cells, and we have these individuals, there were about 230 individuals. They were randomized to either be on carnosine or placebo, and then they were fed carnosine 2 grams per day for 3 months, and looked at the uptake of carnosine in the red blood cells. And we can see that at baseline, there was no difference, but upon feeding carnosine, there was an increase in red blood cell carnosine. So it means that the treatment is leading to an increase in carnosine levels in vivo. But then we said, if suppose we cannot get muscle biopsies from patients, we did do some biopsies in our preliminary data pilot studies, but it is a sort of involved process, especially people who already have claudication and are particular about that. So could we do this non-invasively? So we thought, okay, let's see if we can use mass spectrometry to be able to measure the levels of carnosine in skeletal muscle. And so for that, we enrolled another 32 patients. And then after that, after exclusions, we got about 29 patients that we could have evaluable data from. And so this shows an MRS of the skeletal muscle, and there are 2 minor peaks. So these peaks are representative of carnosine. They're still a little blips, and so although we think we can do a mass spectrometry for spectroscopy for measuring carnosine, its efficacy is borderline, but we would going to then compare it to, could use it as a modality in addition, in case some people don't give us sort of tissue biopsies. But our plan is to measure tissue biopsies. Interestingly, we could see a decrease in carnosine levels in people with scoliosis, so they have less muscle limb use, and we could see lower levels in females versus males, as we did, and we also saw lower levels in vegetarians than in people who are eating meat. So, but then we wanted to see whether there's an association with different compartments of carnosine. So we measured look at the association of carnosine in the muscle versus carnosine excreted in the urine and in red cells, and so that we could see whether this is actually reflective of anything. So we found sort of reasonable, moderate association. So yes, if we don't get to use the muscle and use biopsy, the second thing would be to use mass spectrometry, and if that doesn't work, then we can use the actual measurements in the urine or red cell. So this is a trial. We call it the CAR-PAD trial, which is our study design showing that we would first do a 6-minute walk test on a treadmill. We measured ABI. We take muscle biopsies. We do metabolomic and proteomic studies. We collect blood, urine samples, do MRI and MRS. Then we can randomize these patients to carnosine and placebo. It's not as straightforward as it sounds. We have to get a special compounding to make the placebo for us, and the pills need to be exactly the same as a treatment arm. And then we have to randomize, and we have to randomize in certain blocks so that we don't sort of overlap. And then we have to make sure that each of the categories are filled, so we just don't enroll all women or all men or all white people or Black individuals. So we have to sort of balance our randomization. So it's very complicated, but regardless. And then we put these people on carnosine or placebo. And we bring them back at 3 months. So we will bring them back at 3 months and then do 6-minute walk testing ABI, blood urine collection, bring them back again in 6 months for more extensive tests. And then after that, we will do a 9-month thing and to wash out carnosine after 6 months. Then we will sort of leave them on their own and say, if you want to continue with carnosine, you could. Several patients that we treated with PhD so far wanted to continue with it. They said, we feel so much better. Can we just keep using it? And it's freely available and everybody can use it. to show if you want to continue. So you want to follow that. How many people would actually stay on this as a supplement? How many people will come off? That may be another indirect measure of efficacy. So, and then we would do quality of life measurements and other evaluations when they're off the trial for about a year. So we are excited about this, and we will look forward to doing this. And I want to sort of end here, thanking a lot of people who have been involved in this. Shahid has been spearheading this, and he's a PI on this. We have other PIs who have yet to work on this, but we hope they would. We have Dr. Dwivedi from surgery is involved. I think Satya and Shri from endocrinology are going to be part of this trial. We hope to conduct it here, and maybe if possible, we will recruit some participants from VA and from the Jewish Hospital, and particularly want to acknowledge funding from the NIH. We did, like I said, we were funded to do the initial, what we call the NEAT trial from NIH, and this is the other new trial that we funded from starting from this month, so that we would be able to sort of test all the the results of the pilot studies that we did. And we hope that this would then establish the efficacy of carnosine, which is an innocuous drug, although we did not, it is used in food supplement, but since we were indicating it for use of a disease, we had to get an NDA from the FDA to be able to do the testing. But we have that now, and so we are excited that we are on a threshold of something interesting to do. So thank you for listening and for your attention.
Fantastic. No, Dr. Cook run the local, but I got to start off with the chair's question, of course. Really, Dov, congratulations on all you've done so far. The improvement in blood flow is very impressive, and that dovetails exactly with why I'm here and chose to come to the ASNC meeting. That is, once we have not had PET perfusion, myocardial perfusion here at University of Louisville, and it was approved in our capital equipment, so we will be getting it. And the most important thing we could tell you is that it actually does absolute myocardial blood flow. So coronary flow reserve can be tested, but also absolute blood flow. And so using rubidium 82. And so this would be a great opportunity to test in our coronary disease patients, hijacking what you're doing just very, very slightly, as you gave a wonderful background. This is an opportunity to, and as I searched the literature while listening carefully to you, no one has actually done this yet. So it's novel work, and it would be a tremendous improvement for our patients if we could improve not just endothelial progenitor cells to improve the vascular anatomy, but also the physiology. So we're very much looking forward to all that you do with this, and we can sort of transmigrate back to the heart.
Yes. So what I did not present here were all of preclinical data with mice, which showed that carnosine is very effective in preventing recovery or preventing myocardial ischemic injury. So we've done a lot of studies in which we've done isolated hearts, in vivo hearts, and we have shown that when you treat mice with carnosine, that it could improve myocardial function. We do not know if it is because of increased blood flow. We've also found, and I don't know, maybe Dr. Baba is going to present this in this afternoon, but part of that is that in heart failure, it's very effective. And it works with both in HFrEF models and HFpEF models, that we can see improvements in function. We had no means of measuring blood pressure. We have blood flow in the heart in the mice. We've been doing it for other studies. One of the interests we have in coronary blood flow is because of exercise. And what happens during exercises, when your heart rate increases, the coronary vessels dilate to meet the demand. Now, we do not know what the mechanism for that is. So one of the projects that just got funded yesterday is to study how this particular dilation happens. What are the exact metabolic signals that tells the blood vessels to dilate upon demand, in the coronary blood vessels to dilate? And so we have got now this procedure that we worked out in mice to measure blood flow, and certainly measuring it in people would be wonderful. We've been talking to Dr. Cholera to be able to have a trial with carnosine with heart failure patients and blood flow measurements. So it'd be something that would be very interesting and perhaps useful for us to do.
Fantastic.
All right, do we have any questions from the audience? It's along the lines of Dr. Williams' thoughts about looking at cardiac blood flow. But I was also wondering if you could tell us what we know about hypertrophy of cardiac muscle and whether or not that is a risk to using carnosine. So in a heart failure patient, when you're trying to recover your cardiac muscle, that could be a benefit. But say in these younger athletes who are taking the carnosine for other purposes, do we know if there's actually any risk to a pathological hypertrophy of cardiac muscle?
So there are two types of hypertrophies, right? So one is the physiologic hypertrophy that happens in athletes, so the athlete's heart. And then there's a pathologic hypertrophy, which happens upon heart failure. We don't quite know the difference mechanisms wise and how it goes in one path or the other path. The short answer is we really don't know what the effect of carnosine is going to be on physiological hypertrophy. And that's a good question. And frankly, we didn't think about that. So thank you for pointing that out. Because what happens in athletes, there's hypertrophy, and people who are taking carnosine, we can actually do echo and look at what the cardiac function is in a normal athletes and athletes on carnosine treatment. But what we have is mouse data. In the mice, when we do heart failure, and we give them carnosine, the hypertrophy is prevented. So the ejection fraction is preserved by treatment with carnosine, and there is less muscle growth. So, which is surprising because skeletal muscle hypertrophy and cardiac hypertrophy should both be enhanced by carnosine, and that's what we were saying. But in case of pathologic conditions, it seems to be attenuated. But we do not know what will happen in sort of human heart failure patients, and so we'll be studying that. So thank you for pointing that out.
Any other questions?
Yes.
So I have a question about the dose of the carnosine. How can we determine what's the optimized dose to be effective but without the effect on the human subject here?
So we started off with not knowing what particular dose to use. So what we had to convince the FDA that we're not giving perhaps super high dose so that we can, harm people in any way. So we calculated for a standard American diet, how much meat is consumed and how much carnosine would be ingested by an average American diet. And so we calculated that about 2 grams of carnosine would be present in the average meat diet in the United States. And so said we are doubling the amount of carnosine that people would have from their diet anyway. So that was the dose range we sort of decided to use, and that was okay with the FDA and the NIH. Yes.
Actually, a question. You mentioned a little bit, but kind of the toxicity part of it, is there any downside that you noticed in the mice models or any of the experiments that you did where you were some side effects that you noticed and said, oh, this is something that we didn't really anticipate using the carnosine?
So in the clinical trial NEAT, we had a DSMB, which is to look at any side effects. After we treated 200 people, we got very minimal side effects. We had some cases of nausea and diarrhea, and a couple of people who didn't use it for sensitivity purposes. So that was up maybe about 2 or 3 out of 200 is the indirect effects or side effects. There are not many side effects to carnosine, and that's why we chose carnosine. Most athletes take beta-alanine, and because beta-alanine that gets converted into carnosine, and you can take high doses of it. The problem with that is when you start taking in the first few weeks, you get very dizzy. So you have to keep taking it to adapt to the dizziness of beta-alanine. But with carnosine, there isn't any such side effects, and very high doses are tolerated for years. So it shouldn't be that much of a problem because again, it's just a normal part of food and muscle physiology. Yes, sir.
For any clinicians that you say we don't have a Ph.D. training program, the Healthy Lifestyles program in our own 3 or 4 cardiac rehab programs, they offer for $75 a month exercise training, whether it's for cardiac, pulmonary, or a Ph.D. patient, if they can afford it.
Yeah, so the thing is, I don't know what protocols they use. So the thing with the CLEVER trial, which was a very, very interesting trial, was to use supervised training, and some of these people have trouble walking even a little bit. So if you say, I would, just exercise, or you come to our clinic, we need some specialized training, and then we need to measure outcomes. If we can demonstrate that there is actual benefit to this, that will be sort of duplication of the Clever trial, then that would justify the payment. But routinely, I checked with many of the patients here, they're not referred to the clinic for physical therapy. They are referred to either to be on medication or to undergo surgery. But I would suggest that we should try the actual physical therapy first. And if that fails and the claudication is severe, then maybe you charge people to go in for surgery. Surgery should not be the first line of treatment for people. But the way the system is set up, it doesn't incentivize us to do supervised training. And very few people in our group are trained for PAD patients. There are some specialized centers and we can go learn, but I think that'd be a big addition to our practice. Yes.
In terms of measuring the outcome with the walking test, what difference between the two groups would you define as a clinically meaningful difference for the primary outcome?
So again, going back from the clinical trial, the Clever trial. So if there was, and there was a column there and point out, at least a 2 to 3-fold increase was considered clinically significant in that. So if it went from 2 minutes to 5 minutes, that's almost a two-fold increase. So if we can say sort of two-fold difference, that will be clinically meaningful. But the question then becomes, is how long that benefit remains. So as long as they're on the drug and they do that and they improve, when they stop, does it go back or does it keep on improving over time? So they didn't sort of present the data, but this was the maximal thing they got. And if these people were on exercise continuously, would that keep on increasing? We don't know. So we want to have two-fold increase in walk times and a sustained, at least for 6 months, sustained benefit of in walking. But even then, I don't think that's a big deal. I mean, it may be that it is just walking 2 more minutes, not a big deal, but still to these people, it means a lot. And the second thing is also that this improvement may have to do with decreased claudication. So even if you walk test, so that's another outcome, that if your claudication is decreased or attenuated, then there may be something that's a different benefit than just being able to walk if you don't have pain. So that's a critical outcome as well, and would be clinically meaningful.
And as a follow-up question, do you know what the difference is when people start aspirin or a statin with that sort of outcome, or has that been measured?
Yeah, so statins, of course, are effective. Right. And in terms of decreasing total cholesterol levels, in fact, one other thing I didn't mention, the people in PAD usually have the severe risk for coronary disease because they have very high level, what we say, active atherosclerosis. So that is going to block all the other, or stroke. So most of these patients would die from stroke or cardiovascular coronary disease. But of course, statins are effective in doing that. And actually, statins are perhaps more effective in coronary disease than peripheral artery disease. We don't know what the difference may be. Aspirin is effective in preventing clots and stuff like that. So that's an effective therapy as well. But some people are aspirin insensitive, and it's a very mild anticoagulant. And I don't know, I have not seen what the differences between that and Plavix or some other things are. But that's just, I think, symptomatic treatment. That's not addressing the disease cause. But maybe with the newer anti-cholesterol drugs like Repatha or the PCSK9 inhibitors, that there might be greater improvement. But I've not seen many trials with PCSK9, but I would think there may be some certified.
I want to make sure that we end on time. So, oh, nice, it's unwrapped. So, we know you collect departments, but we think we're the only department who's giving you a slugger bat. So
Okay.
this is for Dr. Bhatnagar. It says Aruni Bhatnagar, Ph.D., Medicine Grand Rounds, University of Louisville, September 5th, 2024.
Oh,
Fantastic.